Good evening, friends. Welcome to the Tuesday Masterclass webinar series presented by Yashoda Hospitals along with the Hyderabad City ISCCM branch. So for this, today's topic is acute pancreatitis. So I would like to welcome the examiners, Dr. Sunil Karanth sir, who is the director and head of the Department of Critical Care Medicine from Manipal Hospitals, Bangalore, and Dr. Arif Pasha sir, who is a professor and head of the Department of Critical Care Medicine from NRI General and Super Speciality Hospitals, Guntur, Andhra Pradesh. So I would like to introduce students, Dr. Prathiksha and Dr. Kirti. Both are DrNB students, second year critical care medicine from Yashoda Hospitals, Malakpet. So Dr. Prathiksha, I think you can proceed with the presentation. So we would continue the presentation from here on.
Good evening, sir.
Yeah.
Good evening, Dr.
Good evening, sir.
Yes. Good evening.
Good evening. Good evening.
Presenting the case of a 50-year-old female patient who came to our ER with complaints of abdominal pain and vomiting. Pain abdomen was present since 2 days. It was sudden in onset and severe in intensity, present in the epigastric region, radiating to the back, relieved on sitting up, and increased with food intake. It was associated with vomiting, which was non-projectile. There was no history of fever, loose stools, or NSAIDs use. Past history: patient is a known diabetic, uncontrolled diabetes mellitus with multiple admissions for DKA, non-compliant with her medications. Patient is also hypertensive. Personal history: no history of alcohol intake, bowel habits were regular. Family history: nothing significant.
Yeah. Dr. Prathiksha.
Yes, sir.
Yeah. Dr. Sunil, can I start?
Yes, please.
Yes. Dr. Prathiksha. So, after going through this clinical scenario, so like, what's your probable diagnosis, differential diagnosis with this clinical picture?
Yes, sir. The differential diagnosis would be either acute cholecystitis, acute pancreatitis, could be a peptic ulcer disease, could be small intestine obstruction, could be perforation, could be mesenteric ischemia. These are the things that I can think of.
Yeah. So how you're going to approach towards this disease?
Sir, if it is an acute cholecystitis, it should not relieve with it should relieve with food intake, whereas our patient has problems after taking food. If it is a mesenteric ischemia, there could be bloody diarrhea. If it is pancreatitis, then the symptoms closely fit in. Relieved on sitting up, also increased after food intake, all of those. Then if it is a
because we are having only the risk factor is diabetes, a female patient with uncontrolled diabetes.
Yes, sir. It can be diabetic ketoacidosis also.
Okay, maybe. Yes.
That also presents as abdominal pain and vomiting sometimes.
Yes.
Any other differential you would want to consider with this history, with radiation to back?
Yeah, pain radiating to the back is also seen in aortic dissection or a myocardial infarction. Even cholecystitis pain radiates to the back. Pancreatic pain radiates to the back.
Sure.
Can it be possible to, because a female patient with uncontrolled diabetes, so probably can it be, think of any pyelonephritis, urosepsis like that?
Yes,
sir, we can think of, but
yes,
there is no fever history, there is no suprapubic pain.
Excellent. Yeah. So nice. Please go ahead. Yeah.
Any other systemic causes you can think of other than DKA or non-abdominal causes for pain?
Myocardial infarction.
Okay, that
yes.
is good.
Aortic
Sorry?
Ruptured aortic aneurysm.
Yeah, that is told already. Maybe very rare but uncommon causes?
In female of childbearing age, it can be ectopic pregnancy,
Yes.
ruptured ectopic
Ruptured
pregnancy.
ectopic.
Very good.
Porphyrias as well.
Yes.
Okay. Yeah. Right. So
Yes.
I think it's a good differential, but always in the mind, I mean, always the approach was right, but in your mind, always have a framework when you're talking about acute abdominal pain. Just have a framework such as inflammatory, in which you have infective, non-infective, traumatic, maybe malignant, congenital. So just have a framework, especially even when you're writing your theory answers, it will help you if you have a structured approach. Okay. But while telling it out, you did the right thing, because you have to put the most likely probability of the differential first, followed by the other differentials one after another. But just have a structure, because sometimes we may say, why do you say rule in and rule out certain things? As Dr. Arif already mentioned to you. So it's important that when you give the differential, you say this is my first diagnosis because of this, and maybe not because of this, like that. Okay. Yeah. Right. All right.
Proceed.
The patient was treated elsewhere for 1 day. CECT abdomen revealed acute pancreatitis with bilateral pleural effusion and minimal ascites. CT severity index was 8/10. Serum lipase was 515 and amylase 955. Serum creatinine slightly elevated 1.8. Fasting blood sugar of 445. Total leukocyte count of 15,300. Trop T was negative and LFT was normal. She was started on injection noradrenaline infusion and shifted to our center for further management. General examination. Patient is moderately built and nourished, conscious and oriented. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Her vitals were: pulse rate was 130 per minute, which was feeble in volume. Blood pressure 90/50 on noradrenaline infusion, 1 mics per kg per minute, double strength, 10 ml per hour. SpO2 85% room air. Temperature, she was afebrile. Respiratory rate of 45 per minute. Her pain score was around 7/10. GRBS was 260 milligram in the ER. ABG with 15 liters O2 via NRB and mask. Her pH was 7.54, PO2 of 57, PCO2 of 28, bicarb of 28, lactate of 4.7. We did a POCUS. It showed basal V profile. LV function was good. IVC was totally collapsed.
Yeah. So at this juncture, can we go back?
Go back to the previous slide, sir.
Yes. So here the case has been transferred from the outside.
Yes, sir.
So we got a clue here.
Yes, sir.
They have already been done the CECT there.
Yes, sir.
Okay. So with this, you're having one clue that the patient, we have narrowed the diagnosis at this juncture. Okay. The source is probably the pancreatitis, as we have already discussed. So what do you think? What is the role of this lipase in the diagnosis here?
Lipase is more specific for pancreatitis than amylase. It has a longer half-life of 7 to 13 hours, and it remains in the bloodstream for around 2 to 3 weeks. Whereas amylase half-life is only 10 minutes, and it remains in the bloodstream for 3 to 5 days. Amylase is non-specific. It can be elevated in several other conditions also, like small intestinal obstruction, mesenteric ischemia, salivary duct obstruction, ectopic pregnancy, rupture, all of those. Peritonitis.
Perforation, yeah.
Perforation.
Perforation. So if the patient...
Sorry, go on.
Go ahead, Sunil.
Can you give me a clinical criteria for the diagnosis of pancreatitis?
Yes, sir.
Clinical criteria, there is 2 out of 3 criteria should be met to diagnose the pancreatitis, sir. It includes the clinical criteria, characteristic abdominal pain, that is epigastric pain that radiates to back and that relieves the leaning forward position and that increases with the food intake. And serum amylase and lipase rises up to 3 times the upper limit. And the characteristic findings in the imaging, sir, like in CT or MRI or ultrasound abdomen, sir.
What are the indications for CT scan very early in the course of pancreatitis?
CT scan is not indicated on the day of admission.
Agreed. But what are the indications when you would consider CT scan?
When there is diagnostic dilemma, sir, if they present in not classically, then we will go to the CT abdomen to rule out the other causes.
I would like to add that if the patient is not improving despite our efforts, so then we will go for a CT scan.
Otherwise, when is the most ideal time to do a CT in the natural history of
48 to 72 hours after the clinical.
72 to 96 hours.
Post day 3 to day 4. Yeah, correct.
So the other thing is, along with the criteria, what you have said, when an elderly patient more than 40 years present with the first episode of pancreatitis, we have to exclude the neoplasm also. Then also indicated the CT. Okay, please go ahead.
So the general physical examination.
We have finished this.
Will I report? Oh. Systemic examination. Per abdomen was distended. Diffuse tenderness was present. There was no guarding or rigidity, no organomegaly. Bowel sounds were present. RS tachypnea was present. Bilateral air entry present. Bilateral basal crepitations were there. CVS and CNS, there was nothing significant. So first we had to stabilize the patient. Two large bore IV cannula was secured.
Okay, can you, I know you have written up here just for the benefit of the audience. Can you tell me how will you approach this patient when this patient comes to you in the emergency department? So you know the history, you know the sequence of events, you have made the diagnosis, and the patient has now come to you with this picture, isn't it? So can you give me the full diagnosis in one line?
Severe acute pancreatitis in hypovolemic shock with multi-organ dysfunction.
Can you classify acute pancreatitis based on the severity?
Yes, sir. Revised Atlanta score.
Modified Atlanta classification 2012, sir. It is classified into 3 types: mild, moderate, and severe. In mild cases, there is only no organ failure. They recover well within 1 or 2 days. In moderate, it is of local complications or with organ failure that persists more than 48 hours. And then severe.
So it is presence of local complications with or without. Okay, even if there are no systemic complications, it comes as part of that based on the timeline. All right, plus or minus it is. Okay.
Yes.
And severe, it is of organ dysfunction that persists more than 48 hours with necrosis of pancreas.
Yeah. Some people even add a 4th category called critical if it goes beyond 7 days. But anyway, that's not needed. This is the Atlanta classification, what you said, revised Atlanta. Okay, good.
Yes. Depending upon the radiologically, how it has been divided?
CT severity score is there, sir, which includes Balthazar score with the pancreatic necrosis.
Like classification, it is divided as interstitial edematous as well as necrotic. Like yes.
So what sir was asking was not the severity. He said, how is it classified based on CT? So that is, so if that comes, you have to say interstitial edematous and necrotic. All right, so give us the full diagnosis and then we'll talk about approach. I know you have a slide which is saying how to approach, but we just let us say in the exam when you are said, we will ask, the slide won't be there obviously, isn't it? So what is the full diagnosis you're going to present after the end of the presentation?
Sir, severe acute pancreatitis secondary to hypertriglyceridemia, hypovolemic shock, multi-organ dysfunction with pre-renal AKI and ARDS.
Sure.
Yeah.
So what is going to be your approach now? You have this patient who has come to the emergency with all the parameters. If you want, you can just go back to that slide with the systemic examination. Yeah. So based on this one backward, sorry. Yeah.
Yeah. This slide.
Yeah. Now tell me, you are called by the emergency team to evaluate the patient. So what is going to be your suggestion and how are you going to act?
Sir, as she is hemodynamically unstable, we should resuscitate her first, sir. And then we should resuscitate simultaneously. We should resuscitate and intubate her to protect, to reduce the work of breathing, as she is having severe hypoxia and severe hemodynamic instability.
You don't want to try NIV or HFNC?
No, sir. She is having severe hypoxia with pain abdomen and severe NORAD requirement with 1 mic per kg per minute. Yeah. We can't give a trial of NIV, sir.
Sure. So I think very important take-home point. Excellent. Exactly what you said. Because the natural tendency is to put HFNC, NIV, slap it on the patient's face and watch. And I agree with you. And I think this is something I want all the trainees to understand, that this is one patient where we are not going to try HFNC. We are not going to try NIV. There is no point in wasting time and delaying it. Intubation is the way to go. Okay. And not based on evidence, but just based on empirical practice. You know, if you have two system failure in cardiorespiratory, if you have two system failure or dysfunction, the natural choice would be to consider intubating these patients. Number one. Number two, always remember, I mean, not in this case, but if somebody has metabolic acidosis, never try NIV on these patients, because one of the common causes for breathlessness, either in this setting or in the setting of any other situation where we have metabolic acidosis, is there is naturally going to be increased respiratory drive and associated increased respiratory minute ventilation. And patients often say, I'm breathless, I'm feeling unwell, etc. So don't try NIV on these patients. That's very important take-home point for this thing. And you rightly said, intubate this patient. Just a small modification, what I would suggest when you're presenting this in the exam. See, exam is two things: assessment of knowledge, assessment of how you put what you know. And it's basically a little bit of dramatizing acting, which you have to inculcate that thing. So when in the exam, always say I would start with an ABCD approach. You know, that just puts the examiner at rest. Some old timers like me, you know, we feel comfortable that you know how the sequence is, because that is what we want you to. You're not a physician, you're not an anesthetist here. You're a mix of two, okay? Yes. So you're going to be ABCD approach. I will assess the airway breathing. Then you say whatever you said it rightly, but just put it in an ABCD sequence, okay?
Okay, sir.
Right. Yeah. The one thing. So here the patient is going into impending respiratory failure. Okay, about to impending respiratory failure. So what all the possible causes of respiratory failure in this case, in pancreatitis?
Because of increased abdominal pain, there is splinting of thorax, or it can be due to ARDS, or it can be due to basal atelectasis, or it can be due to pleural effusions. And because of pain, patient may not be able to take properly breathing.
Yeah, because this is, as previously discussed, about while we are going to secure the airway, we have to be very cautious, because the patient is having an increased work of breathing. So after giving any drugs, the patient may go to collapse. So we have to be very cautious while taking that, while going to for the securing the airway also. Yes, please. Go ahead.
Just in continuation with what sir has mentioned, just wanted to know, say you intubated the patient, you are in the ER. What is going to be your ventilator setting to begin with?
The patient might be in ARDS. So the initial ventilatory strategy would be low tidal volume, maintaining a plateau pressure of less than 30 centimeters water. PEEP, oxygenation wise, PEEP, we are not aiming at a very high PEEP, because patient is already hemodynamically unstable. So these are the initial.
Yeah. So more specifically, can you comment on the minute ventilation here?
Yes, sir. She is compensating with high respiratory rate with the low PCO2. We should maintain the high minute ventilation.
Yeah. So that is very important. I would agree with you saying that I would start. I think it's a balance when you start, you know, maintaining ARDS, because we don't know whether it is ARDS. It could be just, as you said, abdominal pressure or atelectasis, whatever. So start with 6 ml if you want, that is fine. But importantly, and that's what sir mentioned, that he may collapse. Why will he collapse is one of us cause cardiovascular collapse. And the second important thing, one of the most unidentified causes for collapse here is because you have removed the patient's respiratory compensation. So it is very important to roughly calculate what is the minute ventilation prior to what you have intubated the patient, and ensure at least 2/3 of that is being done. Okay. Clear. So it's very, very, and this holds good not only for this patient, but for any patients who are considered as septic and, you know, that kind of a thing. All right.
Okay.
Yeah, just to complete the sense for the house. So in this type of patient, how you're going to take while intubating, what are the precautions you're going to take?
Rapid sequence intubation, sir, with oxygenation with NIV, with the HFNC oxygenation before the intubation, and with the induction agent with etomidate, sir, 0.3 mg per kg, and rapid acting bupropion. We will intubate with rapid sequence intubation by giving the pressure in the precoid area.
Yes.
I would like to keep a suction ready, also the position of the
No, all the emergency drugs will be ready because anytime the patient collapse. So yeah, please go ahead.
So that is all.
Yeah. Proceed to the next. I mean,
yes.
After you can continue.
Shall I?
Yes, please.
Yeah.
I think Dr. Kirti may need to come forward because she seems to be disappearing and reappearing. So, yeah. Right.
Yeah, both of you. Yes.
Yeah.
Yeah, you have placed 2 large bore IV cannulas. You're going to start the resuscitation. So what is the prime aim of fluid therapy in our case?
Sir, she is having acute pancreatitis because of CIRS response. She is having hypovolemic shock. So we should resuscitate her. Fluid resuscitation. She is in obvious hypovolemia, so we should resuscitate her. We
would like to go for a more controlled fluid expansion rather than aggressive resuscitation. The new guidelines say moderate fluid resuscitation is
recent trial was...
Yeah, ultimately why we are more worried about this volume resuscitation in this type of patients?
Sir, because
third space lossing will be
and persistent vomiting, so there is loss of
can you elaborate on that study which you and it's a very landmark paper actually.
Sir, this is a recent trial that is published in 15th of this year 2022, sir. That is prospective randomized trial, multi-center trial. It was conducted in 18 centers in the US. That compared between the aggressive fluid resuscitation and the moderate fluid resuscitation. Aggressive fluid resuscitation consists of 20 ml per kg initial bolus in 1 to 2 hours, and then 3 ml per kg for the in normal resuscitation, moderate resuscitation group, they are 10 ml per kg. There is obvious hypovolemia, they have given a bolus, and then maintained with 1.5 ml per kg per hour, sir, and they are reassessed at 6, 24, 48 and 72 hours, sir. The primary outcome they put was progression into the moderate or severe pancreatitis, and fluid overload is the safety limit they kept, sir.
Yeah. Right.
So in our patient, how you are going to reassess the fluid volume requirements?
So we check for the IVC distensibility in our patient every 4 hours, and then we give another 10 ml per kg bolus.
Yeah, along with this one, any clinical parameters which you can consider?
The endpoints of resuscitation would be hemodynamics, urine output, blood urine nitrogen, and hematocrit.
Yes. So any idea? Yes, please.
What is the target hematocrit?
36 to 48 in females, and 40 to 52 in males.
No. Yeah, below 48, 45. Yeah. Okay.
Yeah. 35 to 44.
Below 45 is what we'll be aiming for, of course, subject to this thing. So one thing I want, you have to personalize it or individualize to the patient. It's not like if somebody, I think the difference was 2.2 versus 1.3 or something. Doesn't mean that you don't go above 1.3 liters or something between the two groups. But you have to ensure that it is done based on assessment, like they have done in that study, which was a good, well-done study, because it was a what we would consider as daily practice kind of study, where they kept assessing the patient after 12, 6, 12, 24, 48, that kind of a thing. So it's very important to ensure that only if the patient needs the fluid, you give it. Okay.
Yes.
Yeah. All right.
So any idea about the ideal fluid regarding the resuscitation in these patients?
Sir, there are recent trials that compared between the RL and NS, where RL seem to be little bit more beneficial in reducing the SIDS and in reducing the SIDS and organ
Yes,
dysfunction.
that's response as well as the biomarkers like CRP reduction also in a small study. So yes. So what is the drawback of this normal saline?
It causes hyperchloremic metabolic acidosis.
If you large enough you use it, there is a possibility of hyperchloremic. Yes.
What are the risk factors or poor prognostic factors in acute pancreatitis?
Bicep scores.
Bicep score. B for blood urine nitrogen more than 25 milligram per deciliter. I for impaired mental status. S for SIDS, A for age more than 50, and P for pleural effusion. If the score is more than if the score is 0 to 2, the mortality rate is 0 to 0.5%. If it is equal to 2, mortality rate is 2%. If it is 3 to 5, mortality rate is around 17 to 20%.
Yeah. What is the score in our patient?
3.
3. It's correlating 3. So which suggests that there is a severity is there.
Yes.
Yes. Okay. What about this harmless pancreatic score?
We are not aware of that.
Oh, no issues. Like, go ahead. Please.
Can I go ahead, sir?
Yes, yes, please go ahead. Yeah. Yes, Dr. Prathiksha, please.
Just a second, sir.
Yes, no issues, please. Yes, yes.
Sir, the initial investigations which we did in our hospital were ultrasound abdomen shows pancreas bulky with altered echo texture, likely pancreatitis. Liver was normal in size with increased echo texture, suggestive of grade 2 fatty liver. Triglycerides was elevated, 1,857 milligram per deciliter. Ionized calcium was low, 2.3 milligram per deciliter. Total leukocyte count 11,620. HP platelet INR was normal. Creatinine was slightly elevated, 1.7. LFT was normal. Electrolytes were normal. Total cholesterol, LDL, HDL, LDL were okay. HbA1c was 12.1. Chest X-ray showed bilateral consolidation with bilateral minimal pleural effusion. 2-day echo and ECG were normal.
Yeah, really interesting. Because other than the alcohol as well as this gallstones, we got triglycerides here.
Yes.
So when these triglycerides are considered to be significant to cause this pancreatitis?
More than 1,000 milligram per deciliter. It is
yes, yes. Very good. So how this triglyceride is going to produce pancreatitis?
Triglycerides form chylomicrons, which impairs the pancreatic microcirculation. This leads to non-release of the enzymes, leading to the enzymes are activated, leading to autodigestion.
Yeah, it will digest, it will destroy the pancreatic injury.
Yes.
Okay, very good. So we have seen alcoholic abuse pancreatitis as well as in gallstones. How this triglycerides, hypertriglyceridemia, pancreatitis differs from them?
In hypertriglyceridemia, there will be no amylase secretion.
Yeah, because we are more worried about the prognosis. When we compare to the alcoholic as well as gallstones, this will have a grave prognosis. We have to be very cautious and we have to be resuscitation early for this guy, for these patients. Okay, please.
Shall I move forward?
Yes, yes, please.
Diagnosis. severe acute pancreatitis secondary to hypertriglyceridemia, hypovolemic shock, MODS, pre-renal AKI, and ERDS. On the day 1, BISAP score was 3. We gave maintenance fluid of 1.5 ml per kg body weight. Patient was on minimal noradrenaline support. Oxygenation wise, we followed the ARDS management of low to idle volume and maintaining minute ventilation with increased respiratory rate and plateau pressure of less than 30 centimeter water, maintaining a slightly lower PEEP. Analgesia, sedation, and paralysis. For that, we used fentanyl infusion and atracurium infusion. Hypertriglyceridemia was treated with plasma pheresis. Nutrition. We initiated the nasogastric feeds at 20 ml per hour, and other supportive care was given with the injection heparin and human atropine infusion and calcium gluconate. Heparin and atropine was given with studies say that it lowers the triglyceride. So.
What are the different etiologies for acute pancreatitis?
Gallstone is the most common cause. Alcohol is the second most common cause. Hypertriglyceridemia is the third most common cause. Hypercalcemia. Apart from that, autoimmune infections like Coxsackie, mumps, hepatitis B, then idiopathic, traumatic.
Any drugs?
Drugs causing are antiretroviral drugs like pentamidine, atidanosin, thiazide diuretics, azathioprine. All of them was pancreatitis.
Okay.
Yeah.
Proceed.
Yes, we have completed the fluid resuscitation. Okay. What about the nutrition in these patients?
We initiated nasogastric.
Before nutrition, these patients will having a lot of pain, no?
Yes, sir.
So how you're going to take care about this pain?
Multimodal analgesia, sir, with opioids and NSAIDs and with epidural analgesia, sir.
In our patient, we gave fentanyl infusion.
Fentanyl infusion, like patient control analgesia, we can go ahead. Okay. Regarding the nutrition?
We initiated nasogastric feeds as soon as she tolerated at the rate of 20 ml per hour.
When are you going to start the feeding here?
Within 24 to 72 hours, sir.
Is there time limited or patient clinical status?
On demand,
we can
low fat diet was started.
Low fat, low residue, soft diet. In case of they are orally taking, if they are ventilated, we should start nasogastric.
What is the clinical status you are going to check before starting feeds?
If the patient is vomiting, then we'll go for enteral nutrition.
Yeah, if his vomiting subsides and pain has been subsides, if the inflammatory markers are coming down, then we can initiate. Okay. So if he is not able to tolerate this soft oral diet, so you're going to go by this nasogastric or nasojejunal. So which is better out of this?
Both are equally
comparable in efficacy and safety.
Okay. So yes, regarding the type of diet, you're saying something like high protein,
low fat,
low residue, low fat, high protein, soft diet.
Okay. So how you're going to check the tolerability of these feeds?
There is no role for gastric volume residual aspiration, sir.
Yes.
If in case of conscious patients, there is any abdominal pain or loose.
Yeah, if the pain persists, again, review back. If the vomiting persists, then we have to think of that the patient is tolerating or not. Okay, initially you will start as you have started here, the low volume like 20-25 ml per hour you can initiate. Okay, right. Yes.
What is your diet prescription? Maybe not in the first 48-72 hours, but once you stabilize with the feed, can you give a diet prescription? I know you said lipid, all that, but in proper sort of in terms of calories, protein.
Low saturated fat and low low simple carb.
How much calories and how much protein?
20 calories per kg per day, sir. With
how much?
20 calories per kg, sir, per day. 1.5 to 2 grams of protein.
Yeah.
Yeah, we are worried about more protein as it's a hypercatabolic state along with the calories. Yes.
Proceed.
Day 2 to 3, patient's hemodynamics were better. She was weaned off vasopressor support. We continued the maintenance fluid. Oxygenation wise, her PF ratios improved to 160. Initially, it was 80. Her pain reduced, a pain score of 4/10. Serum triglycerides also reduced to 512. Renal wise, she was improving. Creatinine was in the decreasing trend and her urine output was adequate. Glycemic control, we maintained GRBS around 140 to 180 on insulin infusion.
Yeah, previous slides we have saw that there is TLC is around 15,000 odd, it seems.
Yes, sir.
So anything about thinking of any antibiotics here?
No, sir.
Why?
Yes, this is only a CIPS response and there is no role for antibiotics.
Pancreatitis is a sterile inflammation, not an inflammation.
So when are you going to think of antibiotics then?
Sir, if patient is not clinically improving after 7 to 10 days of fluid resuscitation and supportive management, we think of infection, sir. Then we go for repeat CT abdomen.
No, depending on the clinical condition. Not only we are thinking of the pancreas per se, extra pancreatic infections also we have to think.
Yes.
So regarding coming to this pancreas, whenever you are suspecting this infected pancreas, how can you get an idea?
By empirically, we can start antibiotics, sir. But CT-guided FNAC we can do and then send them for cultures.
So what most common organisms you'll find?
Gram-negative organisms.
E. coli,
Yes.
followed by Klebsiella.
Klebsiella, Pseudomonas, Proteus, and all that. And along with that, any positive organisms?
Staph aureus, sir.
Yeah. So which antibiotic has been tested previously on this pancreas patient?
Imipenem.
Carbapenem is the
drug
of choice. Also fluoroquinolone and metronidazole.
Okay. Not in our case, anything regarding this fungal, adding of fungal in this patient?
No, sir.
Yes. Please go ahead.
Just a quick this thing. The use of FNAC is now increasingly less and less preferred, because one of the fears is that, I know that evidence says you have to do, but if you look at more recent guidelines, they don't put it very high up in the list of priorities, because one of the fear is that you might actually introduce infection. Of course, if there is clear-cut evidence based on inflammatory markers, maybe total count, day of the illness, presence of CT specific things like air, gas, all these things, only then you would prefer to start without even without a FNAC. The only reason FNAC will be considered is that you're pretty sure there is no infection and you're not sure why patient is not getting better, then CT-guided FNAC. Just, the things have changed. If you look at the more recent 2019 or 2020 guideline, they don't recommend FNAC very high up in the list of things. Okay.
Any role of procalcitonin in the pancreatitis patient?
Yeah, that's
Nowadays, procalcitonin guided therapy is advised. Procalcitonin more than 3.5 nanogram per deciliter on 2 consecutive days, we can start antibiotics.
So,
there is good data to say that use of procalcitonin to guide commencement as well as titration and stopping therapy helps. Okay. Yeah.
Yes, proceed, please.
Sir, on day 4, there were fever spikes, so blood culture sensitivity was sent. Triglycerides were on the decreasing trend. Patient was extubated to HFNC. There was persistent hypocalcemia, which was corrected. Day 5 to day 8, we did a CECT abdomen because there were fever spikes. It showed acute interstitial edematous pancreatitis with CT severity score of 6/10 with splenic vein thrombosis. CT chest showed minimal bilateral pleural effusion, but blood culture showed no growth. Fever spikes had also decreased. We had shifted the patient out of the ICU. On day 10, the patient went LAMA with the following medications: rosuvastatin, fenofibrate, and omega-3 fatty acids.
How do you classify complications of pancreatitis?
Local complications and systemic complications, sir. Local complications include collections, pseudocyst form.
Yeah, pancreatic, peripancreatic, yes.
Pseudocyst
collections, necrosis, and splenic vein thrombosis, and extrapancreatic includes ARDS, pulmonary edema, and AKI, sir. AKI, intra-abdominal hypertension, sir.
So what is Waldorf necrosis?
Waldorf necrosis is peripancreatic necrosis that is defined by a wall after 4 weeks of formations.
It has a epithelial. It has an epithelial layer. Pseudocyst does not have an epithelial layer.
Then acute necrotic collection, ANC?
It doesn't have a defined wall, sir.
Yes, it will not have a defined wall, but it occurs before 4 weeks.
Yes.
This Waldorf necrosis is?
After 4 weeks.
After first 4 weeks. What more? What more complications you will see? Yes, local. Is there any possibility of hemorrhage?
Gastric obstruction, duodenal artery aneurysm and rupture, sir. And thrombosis of splenic vein.
Yes, which has happened in our case.
Yes, sir.
Yes. Then, as you said previously, pseudocyst, peripancreatic collection, pseudocyst will come. Yes. Yes.
So let us assume that patient has not gone lama, and you have said that the fever spikes have decreased or whatever. Say day 11, day 12, new onset fever starts. So how are you going to approach this patient or approach this problem?
It can be due to extrapancreatic infection because of lines. We kept the arterial line, central line, and pulleys, and maybe due to
What is the incidence of arterial line CRBSI? Okay, let me. What is the incidence of CRBSI based on ICNAC data or some other standard data? General incidence in ICUs. You know the number?
No, sir.
Okay. Or what is defined as international standards, at least? Let me put it that way. Okay. So it is a bit variable. I think CDC says around 1 and 2 per 1,000, but less than 1 to 2 is what we would expect. Okay. And arterial line is much, much lower. So when you say, don't say arterial line first, say the other way around. CRBSI, peak, peripheral line, and art line is there. I'm not denying it, but it's generally about half the number of times because it's a high pressure system. Okay. Yeah.
Okay.
All right. Intravascular devices then.
A patient is extubated and she is maintaining on room air. We don't suspect pneumonia, sir.
Why not?
And she is maintaining on room air without any respiratory distress.
Yeah,
No.
you're not labeling VAP.
Yeah, we don't have to say it is VAP. It could be HAP. It could be any other hospital. And,
yes.
Okay. So you cannot say because she's maintaining, there is no evidence of this thing. That is a possibility. Okay. What are the reasons for the patient developing secondary pneumonia in ARDS?
Because of
in pancreatitis? Because
of basal atelectasis, secondary infections are more common.
So it's it could be a resolving ARDS when it is possible. Hypostatic changes, poor, excursion, because as you said, there is splinting, all those things can possibly result in this. Okay. And microaspiration can also happen in these patients. Okay. Yes. Okay. Other sources?
It can be pancreatic necrosis infection also.
Okay.
UTI.
Yeah.
Yeah, it may be non-infectious causes. We can think of any.
Yeah.
DVT. DVT
Yes.
is DVT with acalyclase cholecystitis, DVT.
Any other? So, what are the potential organisms you can suspect to be causing secondary infection or pancreatic, whatever?
Sir, in our ICU, gram-negative organisms are more common, sir. Acinetobacter and Klebsiella, sir. Both
A little more broader. Gram-negative is a very...
Yes, just unmute, sir. Yeah.
Oh, sorry. Can you be more specific?
Gram-negative enterobacteriaceae, sir.
Okay, yes. Like
Klebsiella and Acinetobacter, sir.
Yeah. Then other causes?
Klebsiella, E. coli, Acinetobacter.
Okay, fine. That is gram-negative. What are the causes of secondary infection now? Day 10, say, let us say day 10 in the ICU.
Yes.
Day 10 in ICU, it can be due to UTI or CRVSA or TAP.
Organisms, I'm asking.
Organisms, it can be any organism can be.
Legionella?
Legionella.
No, because you said any organism, I'm asking you.
No, sir. No, sir.
Tell me.
Pseudomonas.
Yes. Yeah. Not very common in Southeast Asia, but yeah. So first three you said is right. What else? Is that all? Is that only gram-negative?
Sir, MRSA. MRSA is a...
Okay, then? Abdominal problem, 10 days in the ICU.
Yes.
Fungal infections can also be suspected in these patients.
Time to start getting fungal infections, isn't it? Yeah. Where? Suspecting where you said urine?
No, sir. No.
Okay.
No, sir. In necrosis.
Fungemia is possible, yes. Yeah. And enterococcus, of course, is a potential possibility. Okay. Right.
Yeah. So, yes.
Go on, doctor.
Yes. I assume that this patient has been given overzealous fluid resuscitation. So, what you will be expecting here as a complication?
Intra-abdominal hypertension, sir.
Okay. How you're going to monitor that?
We use police catheter, which is connected to a urinary bag, and there is a transducer, which should be kept at the level of the iliac crest cross section with the mid-axillary line. Then we need to fill the bladder, and then we clamp it, zero it, and then we can.
What is the normal intra-abdominal pressure?
0 to 5 mm Hg.
5 to 7.
When you're going to say it as intra-abdominal hypertension?
It is grading.
Sorry, sir. Intra.
When you're going to say it as IAP, intra-abdominal hypertension?
More than 12 millimeter.
When you're going to terminate as ACS, abdominal compartment syndrome?
More than 20 with new organ or worsening organ failure, sir.
Yeah, persistent organ failure along with that. Okay. Any role of ulidastatin in our patient?
Yes, sir. There is a retrospective.
How it acts?
It is a trypsinogen inhibitor, sir. Certain peptidase inhibitor, sir. It reduces the inflammation also. There is a retrospective study in 48 patients, sir. There is mortality benefit and there is decreased organ dysfunction also, sir.
It also inhibits local inflammation by inhibiting elastase, and it also acts on the coagulation pathway. It inhibits 9, 10, 11, and 12 factors. So microvascular thrombi is also reduced. So it prevents pancreatic autodigestion, inhibits local inflammation and microvascular thrombin.
So in our patient has progressed to multi-organ failure. Okay, how you are going to prognosticate the patient and communicate to the family members?
According to the PISAP score, the mortality rate would be more than 20%.
No, let us assume that sir and myself are the brothers of the patient. How are you going to tell us?
We should
on the first day or no?
No, day 10. Patient, we are requesting to be discharged against medical advice. What is going to be your counseling to us?
Patient has pancreatitis because of hypertriglyceridemia, which can reoccur. So
that's why, doctor, we are taking her home.
Yeah, bleeding and going back. Yeah.
So then we will discharge with the following medications and advise a low-fat diet, advise weight reduction.
But doctor, you said patient has kidney problem, breathing problem.
Now the renal failure has settled.
Let us say patient is in the ICU still, 10th day, maybe extubated but still on HFNC. Leave the last line that whatever that you said, etc. But say the patient is still in HDU, needing on and off HFNC, some AKI 1.8, and we are asking for discharge.
Sir, we will make them sick first, and then we will address the issues and the prognosis of the present condition of the patient, and then what else we can do.
Assume that I told you, me and sir.
Because we are the anxious brothers of the patient. Because my brother is not having any alcohol habit. He's not having any stones also. But he got this. Why, doctor?
I will counsel them that hypertriglyceridemia is the cause, and it's the third most common cause. Need not necessarily be an alcoholic or be having gallstones.
Yeah, at this junction, what are the possible secondary causes of this hypertriglyceridemia in our patient?
Diabetes.
Yes, one of the most common. Yes.
Hypothyroidism.
Yes, possibly obese patient also.
Obesity. In pregnancy, not in our patient, but in general, pregnancy.
Yes.
Some drugs like glucocorticoids, beta blockers, yes. Isoniazid, isotretinoin. These are the drugs.
Yes, please proceed. Proceed by explaining.
So I would tell that the renal function can worsen. Also the ARDS can worsen.
So doctor, we are ready to spend any amount of money, doctor. Can you make our brother all right?
Yes, sir.
What guarantee can you give, doctor?
Sir, we cannot give any guarantee, but what else we can do to improve the patient, we can explain them, sir.
We can give supportive care, and we will wait.
What do you mean by supportive care, doctor? I am an IT engineer and my brother is a chartered accountant.
Sir, with empathy, we can explain the issues to the patient attendant, sir. Like we also know the patient. If we were in your place, we also feel the same way, and this is very unfortunate thing to happen, and we don't have anything much to do, but we should continue the care as of now and should wait for the results to come.
Supportive
care.
Is
there a chance, doctor? Is there a hope we can keep, or there is 100% no hope?
Yes, there is hope.
There is hope, sir.
All right. Right. Just put it into direct speech. Okay. Say what we are trying to tell you. I know it's difficult in online thing to get that, show that empathy, sympathy, whatever. Yeah. So always have the structure of spikes, as we call it, for the protocol of this thing, planning, preparation, making sure that the environment is correct. So when on the exam, what we expect is that we will be talking directly. That many times I will say, I am the relative. How do you talk? So you would introduce, make it. You told that verbally, but make it to happen that way. All right. Yeah. And also cut down on all these medical terms, supportive, this, that, even now, I think your first year, isn't it? Practice it from now itself to put it down into layman terms.
Yes, yes.
Okay.
Yes.
Right.
Yes.
Anything else, doctor?
Yes.
What are the indications for surgery in acute pancreatitis?
Polycystic, if there is mild pancreatitis due to biliary pancreatitis, in mild cases, we will go for polycystectomy in index hospitalization. Sir, if it is necrotizing pancreatitis, we have to wait till the pancreatic necrosis has walled off. Then we will proceed for cholecystectomy. If there is biliary stones with biliary cholangitis, we should go for ERCP within 24 hours, sir. There is no suspicion of cholangitis and there is no evidence of stones in the CBD, then we should wait for ERCP.
Anything else? What are the reasons surgery?
Minimally invasive procedures, sir. If patient is unstable with gastric outlet obstruction in case of asymptomatic pancreatic collections, then we will go for surgery, sir.
Minimally invasive surgery in the form of video-assisted retroperitoneal drainage or minimal access retroperitoneal drainage.
Any other complications that would need surgery?
Mesenteric ischemia.
That may need surgery, isn't it? Yeah.
Because most of the time when the patient is going to improve, suddenly the patient may drop the hemoglobin, have a drop in hemoglobin.
Yes.
And the pain in the abdomen will be increases. So what are the possibilities?
Hemorrhage.
Hemorrhage because of duodenal artery erosion.
Yes, possibility of erosion will be there. How are you going to manage that?
Not necessarily only duodenum, in splenic as well.
Any erosions, yes.
We should resuscitate with the fluids and blood, and then we should go for surgery, sir. Surgery and repair the artery. Before that, can we locate that?
You are in the world.
We'll do a bedside ultrasound. We'll do a bedside ultrasound scan and look for any collection.
No. Ultrasound. Okay, fine. You did ultrasound. He said there is too much abdominal distension. You can't make out.
We'll go for CT abdomen, sir.
Yeah. Any role of
size on the CT abdomen means what?
Sir.
What type of CT abdomen?
Contrast CT with CT angiogram, sir.
CT angiogram.
Angiogram. That's the word. Okay. Yes. Because there are different phases in that. No, early, late, mid, and late. So it is a CT angiogram, which is the early part is what is very important. So it is showing a pseudoaneurysm in the splenic vessel, which is showing a blush. What are you going to do? And you are in the world's best center with all possible specialties present.
Yeah, all specialists are there.
Surgeon said, I can't touch this patient. Forget it.
Who, sir?
Anybody interventional person is there to help you.
Yes, sir. We can go for embolization of the artery with
clipping or coiling.
So the first priority is to do an IR procedure if possible, because it may not be very easy to locate the bleeder when there is so much of necrosis and so much of muck plus blood in the abdomen. So IR would be the first way to go if possible. Otherwise, the last option would be surgery. Yeah. Okay.
Yes.
Okay. I'll see if there are any questions, I think, in the chat box.
Yeah.
Sir, there are questions in the chat box.
Yeah. Yes. So the first one, 722. Okay. Is really etomidate and other inducing agents needed because they are respiratory exhausted? Fentanyl alone can't do. So that depends on the clinical situation, I suppose. Again, etomidate is controversial. I think a lot of emergency rooms, the ER department still use it. But as we know, many critical care units don't use it. So that's a bit of a thing. But we could use large dose fentanyl alone may not be sufficient many times, then you may have to consider addition of something. If the hemodynamics are good, you could think of propofol or ketamine also can be an option. But often we would need an adjuvant drug to the opioid. Dr. Arif, anything you think differently? Yeah.
Yes.
Yeah. So I think we can't give you a one-point solution for this. Fentanyl alone may be sufficient. You may need a little top up with something else as well.
Yes.
Yeah. The second question, why didn't you use double vasopressor instead of single vasopressor like norepinephrine until 1 microgram per kg? Why didn't you use combination? That depends on center to center. In fact, there is no data to say that addition of vasopressin changes mortality other than sympathomimetic sparing this thing. So I think both are correct. What you have suggested also can be done, or you could even
can be added vasopressin.
Yeah, that's okay. I don't think neither this is correct nor that is correct. Both are acceptable based on the practice of the institution. As long as you don't use dopamine, I think I'm fine with anything.
Yes.
All right. Why use
neuromuscular blocking agent while intubating the unstable patient?
That may cause,
as we know, that neuromuscular may cause stress to volume become fall. Why don't you use ketamine and intubate with sleep without apnea?
So I think partially we answered that question, but we spoke about modified rapid sequence where using neuromuscular blockade is a standard of care. So I don't think there is a reason we should not be using it. Yeah. So again, it depends on the centers. If you are not confident of getting the airway in, then maybe you would use more only fentanyl or only something like that. If you ask me, I think not using neuromuscular blocking agent in these kind of...
Because it's like whenever we are taking care of the patient, it's a balanced anesthesia, what we are doing. It's if you use only the ketamine, you are inducing that. You are not relaxing the patient.
Correct, yeah.
It's very dramatic situation.
Most circumstances, I think it is safer to use than not use a neuromuscular blocking agent unless you are in a place, maybe in a PHC or somewhere where you don't have enough skills to support you, that's different. But I think for all practical purposes, if you look at the definition of RSI or modified RSI, it is using NMBA is there. So, yeah. Why did you use large bore IV cannula instead of CVC?
Yeah.
No, I think resuscitation here is always with the peripheral line large bore.
After occupancy, we can use. Yes.
Correct. In fact, there is even data to say that up to 0.5 mics per kg, you can even run NORAD through a peripheral line.
Yes.
So CVC is a semi-elective procedure. So don't think we can use CVC here. You can administer vasopressor directly while measuring CVP for fluid monitoring. CVP is a questionable thing. So I think we'll not go into that debate. It is
because already we have came to the dynamic parameters now.
Yeah, it is all. CVP itself for fluid monitoring, as we know, is not the standard of it. It is like tossing a coin. Sensitivity is 53%. So, in fact, if you ask me, I would even say IVC is as bad or marginally better than CVP. So you have to look at a combination of things. So since somebody has asked this question, we'll just touch upon it very, very briefly.
Yes.
Hemodynamic assessment today is not one parameter. You have to look at the etiology. You have to look at the fluid balance in the last 24 hours, the necessity and the need to give fluid or not. So we always talk about volume responsive state. See if the patient is volume responsive or not. It is so if a hypotension is there, and check if there is volume responsiveness, either PLR or any other phase. You can have your pulse pressure variation, systolic variation, whatever. But we also look at the lung. How bad is the lung? Whether there is enough variation. So IVC, VTI, all these factors you have to see and only take a call. And as we discussed, if you have already loaded the patient with enough fluid, then it may not be right to give more volume. So we always look at the lung. Today we use ultrasound to see if there's early ARDS setting in, if the fluid is, interstitial fluid is worsening in the lung. So a lot of things need to be, so we can't give you a one-point answer for this. This is a one-page answer. And again, individual. Yes. Sir, you can correct me if I'm wrong. So,
yes, sir. Yes. Please.
Any role for probiotics? No data to support it at the moment.
And there is a negative outcome also with probiotics. So better not to touch. Yes. No role.
Is there any amylase? What is that? Amylase study for
this patient to diagnose acute pancreatitis? Like it's an enzyme. What you're talking about, amylase?
I'm not too sure if there's been any study done. But I think it's more before the time of EBM itself, we are aware that amylase lipase, the difference is known. So I don't think there is, I don't remember at least any study.
No, nothing like
I'm
that.
subject to correction.
Yeah. Did you use bundle of sepsis against this patient? Why there is no antibiotic and blood culture study? Yeah. Already when the patient has got this fever, they have already sent the blood cultures. Yes.
To the presentation, so I'm sure they will have done it, doctor.
Yes. Because here the point what we want to stress
the
is...
focus here was on pancreatitis, so I think
that's
why, don't worry, they will have done it.
Done it, yes. It's a protocol with patient on ventilator and control line. No need to start antibiotic. Yes.
No need unless you have evidence to say or you're suspecting infection. Okay, just in that line, so many authors do believe that if there is worsening multi-organ failure in the first 72 hours, you could start an antibiotic. Now, this is a debatable point. There are people who believe that you may have to consider starting antibiotics in the first 3 to 5 days if you don't find them getting better in spite of optimal supportive measures. But this is a debatable point. And if you're starting there, don't start meropenem. They would consider starting something more third generation cephalosporins or BLBLI. But this is again debatable. I'm not saying there is data to support it. And if you're losing a patient, then obviously, you would be tearing your hair and you would throw everything at them. But presence of lines, presence of tubes, presence of ventilator is not an indication for antibiotics. If that was the question, that is the answer.
Yes.
Why some people of alcoholic patient getting pancreatitis and not at all? That I don't know, man. There are, if you ask that way, it actually depends on the dose of alcohol. And most often, somebody who is a chronic alcohol consumption person, I won't call it as alcoholic because there's a definition. So let me say somebody who's consuming alcohol every day has a binge. So many times acute pancreatitis is precipitated by a binge. Second thing, many patients who have chronic consumption of alcohol may have underlying chronic pancreatitis as well, especially if there is 2 or 3 recurrent pancreatitis in the past or acute pancreatitis in the past. 50% of them will have chronic pancreatitis on the background. So that can predispose to this as well. One more theory is that there is nutritional factors also involved in these patients developing pancreatitis. So that could be the broad answer to the specific question, but otherwise I cannot predict. In fact, there is some data now emerging that there could be genetic factors also, coming in for somebody who can be predisposed to pancreatitis. The SPINK gene, there is a plus gene. There are a whole lot of genes which are being studied, and that's the data which is now coming out, especially for idiopathic pancreatitis or even autoimmune pancreatitis. Many autoimmune pancreatitis are associated with IG4 disease. So these are all things which are in the pipeline. But if you specifically say why this alcoholic has that alcoholic doesn't have, I can't answer that. But risk factors are dose, binge drinking, and if there is any past history of pancreatitis for alcohol particularly.
Yes. GPS because of lines. Yes. If you are suspecting any line, infection, we have to send the cultures and we can start with antibiotics.
Lines also, and even otherwise, by the second, third week, you actually find that enterococcal septicemia is not common. MRSA maybe is less often, but because this is an abdominal issue, enterococcus is not uncommon. But in our setting, it is, as Dr. Prathiksha and Kirti said, it is predominantly gram negative. And this is also supported by the ICCM data, which we have, the INDICAPS data, and also from the EPIC2 data. So that's what.
Yeah. Indication for parenteral nutrition in acute pancreatitis.
So the answer would be feed every possible way enterally. If you can't feed, only then we talk about parenteral. And we wait for parenteral nutrition till day 7. So the general guideline is that by day 6 or 7, if you can't reach 70% of the expected calories and proteins, then we can consider partial parenteral or total parenteral, depending on the how well you can use the enteral route. So nasogastric, not possible nasojejunal, do everything possible. By days 6 or 7, you're not able to achieve targets, only then we think about parenteral nutrition.
Because enteral is the best possible to prevent the translocation of bacteria also.
Yeah.
It will be more helpful. Yes. Any role of minimal invasive surgery in refractory pancreatitis with local complications?
I think we touched upon that already.
Yes, yes, we have gone through
So,
that.
large, for all practical purposes, we wait as long as possible. As Kirti or Prathiksha, one of them did mention that until it gets walled off, the surgeons or anybody would not want to touch. And if they touch, it will be through minimally invasive approach. It could be video-assisted laparoscopy. Sometimes we can approach it through a transgastric approach. So these kind of things are attempted. Yeah.
So can we try HFNC in this case as patient is not resuscitated properly?
No. Answer is no.
Yes.
Big no with the block letters.
Yes. Why did you start with 1 mic per kg per minute of NORAD?
No, they have titrated it up to that level.
Titrated, not straightly starting for that. Volume resuscitated, after that we have gone to that. When we can start TPN? Yes, already discussed.
We spoke about it.
Yes, role of immune nutrition.
No data. In fact, if you look at the, what is that study? Glutathione. I forgot the name of redox.
Redox, yes.
It actually showed harm. Though I don't remember how much of them were pancreatitis in that, but I think there is no data. And I think
presently no data.
If you look at most immunonutrition markets, they've actually stopped coming to us to even talk about it. Data has shown it to be not useful.
Yeah. Can you explain why NIV was not tried? No, because already discussed this.
I think we discussed that already. Yeah. Cardiac output monitoring. If you are having money, all that
go ahead,
you can, but we have that data now possible with the bedside ultrasound, a lot of other things, and so I don't think we actually have to use cardiac output monitoring.
Yeah. So yes, are you saying CVC use is not indicated? Central venous catheter.
Not say that actually.
No, we have not told like that also. Yes.
So what we said is bring the patient to ICU, then take your time and put a CVC if need be. Okay.
Yes. Acute pancreatitis with pre-renal AKI. What about the fluid management in this patient? Already discussed.
We discussed that, yeah.
Yes. Harmless pancreatitis syndrome. Syndrome or score?
Score.
It is a score. What we have discussed.
For acute pancreatitis, mild acute pancreatitis.
Yes.
So there is a lot of data to support, to actually help in prognostication and other things with mild pancreatitis. Okay.
What we say is it's a three parameters. Yes.
Yes, sir. One more last question is there, sir.
Yes. Can you mention the evidence that tells the Procal can be used to initiate the antibiotics? So,
there are a couple of small studies which have used. I think one is I'm not sure if there's an RCT, but there is one single center study and one more. I don't remember the name of the authors. Both have shown that using a procalcitonin guided. This is for pancreatitis I'm talking about.
Yes.
General ICU data, I think you have enough to say that you can use, there is an RCT, as you know, two landmark studies which have shown that you can use procalcitonin to initiate, stop. I think we'll not go into that debate. But with pancreatitis also, there are a couple of studies which have shown that if you're unsure, you can use procalcitonin as a marker to decide when you're going to start antibiotics and when you're going to stop antibiotics.
Yes. Yeah, completed all the questions.
Yeah. Yes, sir. So, so with this, I think we came to the closing of this session. So thank you, Sunil Karanth sir, and thank you, Arif Pasha sir, for your valuable time and sharing your clinical experience.
I think first you should thank Dr. Prathiksha and Dr. Kirti for their hard work.
And thank you, Prathiksha and Kirti.
Participants enthusiastically interacted.
Yes. The participants almost around 180 people logged into this.
Yes.
So I think it was very excellent discussion happened, and acute pancreatitis covered from all aspects, and so many students got benefited.
Yes.
So thank you, Venkat Raman sir, for
thank you, Venkat Raman garu, whole team, Dr. Kaladhar garu, and Dr. Sunil Karanth.
My pleasure.
And Dr. Prathiksha and Kirti. Thank you, one and all, and thank you, participants.
Thank you, one and all. Yeah.
I would, sir.
Yeah.
I would like to thank our HOD sir, Kaladhar.
Yes.
Kaladhar for training us.
Thanks.
Yes,
Thank
yes,
you.
it's really nice to hear.
Yeah.
Thank you,
Thank you.
Kaladhar ji.
Thank
you.
Thank you, Venkat. Yes.
Okay, sir. We'll close the session, sir. Thank you
Yes,
very much.
thank you.
Good night.